Okay. So could you please kindly begin by telling us a little bit about yourself, a little bit about your background, and how did you become interested in epidemiology? And within your impressive professional career, I understand you were part of many health initiatives in New Zealand. Through working with people from all backgrounds, what were the highlights and what were some challenges?
Okay, my name's Tony Blakely. I'm a professor of epidemiology and a public health medicine specialist at the University of Melbourne currently, and I run the Population Interventions Unit and something we call SHINE. Where did I come from? Well, basically, I did medicine, and I nearly pulled out of medicine. I was getting pretty sick of it. It was like learning a telephone directory, very boring. Until in my third year, we had a tutorial where a guy came along and he started talking about medical decision analysis, and then he mentioned this word epidemiology, and suddenly the lights went off for me. I thought, oh yeah, because I enjoyed doing maths and physics and sort of the logical types of things, as well as how social systems affect health. And I saw this thing called epidemiology, and I learned that as a medical person, you can specialize in public health medicine and do epidemiology. And so I was probably one of the first people in my medical class to work out what it is I probably wanted to do, because I was about to leave and I discovered this thing. So I did my medical degree, then specialized in public health medicine and did a PhD in epidemiology at the tail end of that in New Zealand. I spent most of my training and my professional life in Wellington. And for about 20 years, I was a researcher at the University of Otago, Wellington, and there I led programs in health inequalities research. And then I set up something in 2010 called Burden of Disease, Epidemiology, Equity, and Cost Effectiveness, quite a long title. In all those activities, I've been passionate about trying to find those things in society that if you intervene on, will make a difference in both average health, but also in health inequalities. And when you're doing that sort of thing, you can't help yourself but start looking out the front window of the car. Normally in epidemiology, we look in the rear vision mirror. We're analyzing data that's already been collected, which is necessarily in the past. And that's all good and fine. And we do a lot of that. But implicitly what we do when we're doing that is we're analyzing the past, and without even realizing it, we're saying, and this is how the future will be as well. Because we're always trying to do research to inform policy, sometimes purely for knowledge gain. But in my area, there's two reasons you do research. One is for knowledge gain, one is for policy impact. And we're probably a bit more down the policy impact end. That said, you can only be talking to policymakers if you're talking about something that actually is causally associated. So you can't forget your core epidemiology in doing that. Anyway, so looking in the rear vision mirror, and then since about 2010, increasingly looking out the front window of the car where we simulate populations into the future. So how do we do that? We basically create these models of the entire New Zealand or entire Australian or entire South Korean or entire whatever country's population. And we basically have their all-cause mortality, morbidity up here and all the diseases down here. And then we work out what it would be like in the future under business as usual. Then we layer an intervention over it. So, for example, we've just done some highly influential work for the New Zealand government. They commissioned us to look at the tobacco end game, which is quite amazing. So New Zealand has just introduced legislation into the parliament that will take all the nicotine out of tobacco. So it's no longer addictive, reduce retail outlets by 95%, and create a smoke-free generation whereby people born after 2009 will never be able to be legally sold tobacco. So this is radical. If they can get that through and get it back into an actual legislation, which I believe they will, then this will put New Zealand completely at the forefront of tobacco. This will see tobacco moved essentially from New Zealand. So we were asked to do the modeling for that. And so what we did was we simulated this type of modeling into the future. No other country's done it, so there's no actual evidence on exactly what it will do, but you can piece the pieces together and come up with plausible scenarios. So that's the sort of stuff I do. As far as that's just one example of tobacco research. We've done a lot of that. In the last 3 years, we've been busy doing COVID modeling, along with many other people. And we've just launched results actually in the last week, whereby we look at 44 different policy options across 64 different futures, and those 64 different futures are different types of the SARS-CoV-2 virus, whether it's got high immune escape, low immune escape, virulent, non-virulent, what day it comes in, all that sort of stuff. And that's been both great fun, but also I think highly influential to do that, because we're integrating epidemiology, economics, and data science. Very exciting times to be doing that type of stuff. So yeah, tobacco stuff, do a whole lot of housing research too. Housing's a really good example of a social determinant that affects health. It's not tobacco or BMI or blood pressure. It's a bit further back in the causal chain. But actually, you know, there's quite good evidence that things like cold housing affect your health. But the evidence beyond that is really poor. And we need to improve the quality of our evidence on exactly how much people's incidence rate of asthma changes when you change cold housing. So looking at that sort of thing, and that's kind of where I'm at. I moved over to University of Melbourne full-time in 2019. In my previous career at Wellington, I was in a postgraduate school which didn't have a major undergraduate campus. It was a great place, fantastic, knew the politicians, could ring them up, you know, great connections with the policy world. But I've always wanted to get onto a major campus, so I'm really enjoying my time now at the University of Melbourne.
Lovely. Sounds really interesting. So how have the advancements in technology, including vast amounts of data nowadays, changed the way that epidemiologists work? I know you mentioned that you do a lot of modeling. Has there been any significant shifts in modeling in the past 20, 30 years?
So technology's touched on our discipline in many ways. The first and most obvious way is data, or big data. So for example, using a New Zealand example, by virtue of a previous Prime Minister who just said, we shall do it, there is data in one place that includes the justice system, the health system, the tax system. And so you've basically got data on the entire New Zealand population, followed up over 20 years with all these data sets in there. That's extraordinary power to do analysis. So for example, one analysis we've done is whereby you can see when somebody gets coronary heart disease and when they die of a heart attack. You can see when people develop diabetes. And as they develop these diseases, you can see what happens to their income. Now that's really cool, because you can do an analysis across the entire country, controlling for all the other diseases they're getting at the same time, and generate income loss when they get a disease. Now, that's kind of interesting in its own right, but where it's really interesting is you can take those estimates and put them in the simulation models I was talking about, looking out the front window, and you can do stuff like, say, to the Minister of Finance, after you've spoken to the Minister of Health, you say to the Minister of Health, we will gain 600,000 health-adjusted life years by getting rid of tobacco out of New Zealand. And the Minister of Finance is sitting there going, yeah, but I'll lose all my tobacco tax revenue. And then the next thing you say is, and it will save this much in health system expenditure because you're going to reduce diseases, which is another trick we did. But the one I was talking about now is you then also turn to the Minister of Finance and say, and by the way, it's going to make the population healthier. And you'll see $1.3 billion increase in income in the population next 20 years. And the Minister of Finance is going, that'll be increased income for tax that I can use to replace the lost income from the tobacco tax revenue. So that's just one example of big data that you can use to do extra things with your epidemiology. Other ways that technology has touched us is a lot of people will be looking at wearable devices as something they study as a health intervention. Lots of work on that. Another way it touches us is, again, in Australia, we're behind the ball here, but increasing ability to link data sets together so we can do more stuff like what we were doing in New Zealand. In my area, machine learning and artificial intelligence as an analytical tool is really quite interesting. So that machine learning type of stuff, very good at predicting. You know, takes a scan of your face, predicts it's you, lets you in the door. Takes a scan of a cat, sees it's a cat, not a dog. And we can use that because we can use that, for example, based on a whole lot of electronic health record data to say, oh, This is what predicts whether or not they're going to get cardiovascular disease in the next 5 years. So these people that we predict are the ones that we go and follow up more with treatment now to prevent it. So that's pure prediction. The part that I'm more interested in, though, is determining what is causal. Because that prediction, I'll give you one example. There's one of the fats in the blood, something called high density lipoprotein, HDL. It's really strongly predictive of coronary heart disease, but it's not causal. The people who've done the trials that have changed the HDL levels and the people who've done these things called Mendelian randomization studies, it's not causal. It's correlated with other things that are causal. So if you put HDL in a model to predict heart disease, it'll predict it really well. Doesn't mean to say changing the HDL will change their future coronary heart disease. So there's a clear distinction in the use of machine learning between that to predict things and that to help with causal inference. And so one of the areas that we've been looking at, and lots of people are looking at, is that there's this whole blossoming of a new field of causal inference research, where we've learned so much from the randomized trials, but they're expensive and you can't always do them because it's unethical to sometimes randomize people to, have low nicotine cigarettes or not, or whatever. And we're getting better and better at using observational data and making it look like a randomized trial by a lot of hard work. And one of the tricks we can use in there is that when we make somebody who does get a low nicotine cigarette look identical to somebody who doesn't, we can use machine learning to predict who gets that exposure, low nicotine cigarettes or social housing, whatever it is. And we can use the machine learning as a tool in there to help with those weights that we use on the data.
Wow, that is quite detailed and very interesting. Although Australia and New Zealand is currently highly ranked in various global health indexes, are there any health and social initiatives in other countries that we may be able to adopt here or in New Zealand?
First of all, Australia and New Zealand do pretty well. We're pretty high up the rankings, so we shouldn't be beating ourselves up here. But there are some things we can learn from other countries. I'll use Australia as the example, and I've already mentioned is the quality of the data. Australia is just hopeless on its divisions between state and federal, between the states and Canberra, meaning that data doesn't get shared, which means that you don't have a decent enough analysis on it to do things like spot people who are at risk of cardiovascular disease and for an automatic IT system offer them treatment. So there's one thing that we can do much better, and we can look at some of the data linkage initiatives in the UK and some of the health management organizations in the US where they have all this stuff integrated to do a better job. So that's the first thing. Second thing, and this is a live discussion and is going to happen, is that the current government that's just come in has promised, it's in their manifesto, they're going to do it before the next election, is create a Centre for Disease Control. Now, that's a live discussion. It will be under consultation, we believe, in the latter part of this year. And that what that would allow is, people remember with COVID, we had a lot of trouble with national coordination. And ScoMo introduced the National Cabinet, which is probably one of the better things he did. And it started getting some of that coordination going by just getting people talking together, etc. A CDC, if we set it up properly, could become the intelligence above all the states that helps link the data and spot emergent infectious disease, but also deal with non-communicable disease. So there's real opportunities for some national coordination. Very hard to do, though, because the states don't want to lose all their autonomy. And indeed, we learned in COVID, if the feds had had their way, we would have not gone for elimination of COVID in that first year, because the states basically overruled the feds. So there are advantages in having the state federal system. That said, there will be advantages in having a centre of disease control that helps facilitate activity across the sector. So there are two, I think, important examples that we can learn from. Other ones that are sort of down a level beneath the whole system. One, why aren't we taxing soft drinks? I mean, so the UK has a very elegant soft drink tax system. It's actually a levy, and it's very clever, because what it does is it creates pathways for the industry to not just get hammered, to reformulate their products to be lower in sugar. And they've done it. Nobody's complained. The sky hasn't fallen in, and there's going to be a massive reduction, not massive, but a sizable, an important reduction in diabetes, oral health problems for children because of that simple measure. I don't know why we're not doing it here. It seems bizarre. Other things we could be learning, Australia can learn from New Zealand on the tobacco end game. I mean, to say, why not just get rid of this product? This as bad as having asbestos around. Why we tolerate it, I have no idea. So we can be doing that type of stuff. So there's some examples of things that we can learn from other countries to improve the health in Australia. The last thing I'd say is that we're now at 2022. We all live reasonable amount of time. We can keep increasing longevity, but we need to think about what we do in the health area, health policy, health research. I think we need to less just keep bleating on about making people healthier and healthier and healthier and healthier. That's great, but if we're going to make people live longer, we need to do it in a way that's sustainable, environmentally, but also on the health system and on the taxpayer. So increasingly, we need to think about interventions that not only make you live longer, but improve your quality of life and mean that you're more likely to stay productive in the workforce. And unfortunately, for some people, other people, this is okay, mean we can lift the retirement age to make a society that's more sustainable as we age. So we need to think about health interventions that improve workforce productivity, things like that, not just for health its own right.
So I think you mentioned also something about housing before. So what are some of the most concerning health or social trends today, and are there any actions we can take to tackle that trend?
Well, before we get to housing, the obvious one is body weight. That's the one that's going in the wrong direction. So Australia still, it may have peaked, but it has been increasing, and whether or not it's peaked now, we can argue about in 5 years' time once the data's in. But with increasing body mass index, that leads to diabetes, osteoarthritis, and is actually back pain, these types of things that, they're not as sexy as cancer, but they really do impact people's quality of life. So that's something that's going in the wrong direction. It's well known about. We need to treat that not as an individual responsibility, but as a societal one, which is everything from the way that fast foods are advertised, the way that obesogenic environments are just accepted as being the normal, the way that we organize our cities so that people walk around them more rather than drive their car around them, all those sorts of things. So that's it's not only an issue for Australia, it's an issue for every country is dealing with that. The other example you mentioned was housing. Now, it's surprising in 2022 that we're talking about the quality of housing, but we are. And particularly in Australia and New Zealand, we tend to have rather shoddy housing stock compared to European countries, and we have rather shoddy systems. So, for example, only 4% of housing in Australia is social housing, whereas it's about 30% in some of the Northern European countries and Western European countries, i.e. the state is more involved in that provision. And you can just look at the affordability crisis we have now and the intergenerational inequity that's creating. My age and older, about my age and older, we've had it good. We've actually managed to take the gains out of the housing market, but it's very hard for the younger people. So we need to correct that in ways that's beyond health, obviously, but it feeds back into health through anxiety, depression, quality of life, all the rest of it, to make that more sustainable. Now, if we jump into the house itself and think about the conditions in there, a lot of Australasian, so Australian, New Zealand housing is cold, damp, has lots of mold, it's not well insulated. All those things knock on to asthma, respiratory disease, cardiovascular disease, anxiety, depression. And the interesting thing about housing is that the quality of housing is strongly associated with socioeconomic status and indigeneity. So this is something that if you act on, you're not only going to improve the average health of the average Australian, you'll also reduce health inequalities. It's not going to solve all of health inequalities, but hey, public health normally is about doing lots of things that add up. And this is a key social determinant that we should be focusing on more.
Okay, thank you for your time.
Pleasure. I hope that was useful, Stephen.
It certainly was.